All right. For this session, we have with us today a very special guest, Dr. Priscilla Coleman. She is Professor of Human Development and Family Studies at Bowling Green State University. Dr. Coleman is highly published in the area of psychological impacts of abortion on women. Thank you so very much for joining us, Dr. Coleman. It is a real privilege to have you here with us.
Well, thank you for having me, Sarah. I'm really happy to be here and to be able to share the information with you.
Thanks. All right. So before you go into your presentation, could you just give our viewers like a brief, tell us a bit more about your qualifications and experience to talk on this topic?
Okay, well, I'm a research psychologist and my background was developmental psychology, but I've focused most of my publications over the years on reproductive choices. I started out by just looking at the transition to parenting in my doctoral work, and then I began looking at the psychological outcomes of abortion, primarily because I was seeing among people I knew and kind of anecdotal information that women were suffering, but I didn't see it in the published research. And I was sure that there was a lot more to abortion than academics were acknowledging. And so I became very curious and started focusing my research attention on the psychological implications. I've also studied women who are at more risk, higher risk for adverse consequences. So it's a really large literature now. There are other research groups throughout the world who tackled the topic. When I first started, there just was very little. And so that was in the early 90s. And we've just seen a huge proliferation of information. And at my position has always been, since I started, that when you really collect the data in an honest way that is scientifically valid, that the truth is in the data, that abortion is not an easy experience for the vast majority of women, and a certain percentage will suffer dramatically. I now often, in terms of my experience, so I've been teaching at Bowling Green State University now for 20 years. I don't teach courses that are directly related to this topic. I teach development classes, lifespan development, parenting processes, research methods. So all of my research has been on this topic. I think I now have, probably close to 40 peer-reviewed articles on this topic. And I've been shifting my attention to helping various states defend laws that I believe are woman-centered, that allow for women to make informed decisions. So I've helped with waiting period laws, counseling laws, gestational limit laws, mostly with Indiana, Missouri, Utah recently, South Dakota. So it's been really interesting, and it's been gratifying to see that the empirical work is actually now being used to inform policy. And whenever an abortion restriction is enacted, the numbers of abortions go down dramatically. So,
Okay, that's quite extensive. All right. Yeah. All right. So we have some slides that you have provided. But I wanted you to also give our audience a bit of an overview of your methodologies. I know that these maybe have been derived from several studies, so it's not one methodology, but basically what kinds of controls were put in place to test for the confounding factors that you're going to be actually able to attribute what you're about to present to abortion.
okay. Well, because reproductive history is not something that we can manipulate experimentally, we can't randomly assign women to have an abortion, a birth, or place for adoption. So we're using kind of pre-existing data in that way. So we talk about increased risk or associations, significant associations between abortion history and mental health. When you ask women, many women will say and identify it as the direct cause. And so there are qualitative studies and over time, we kind of build a case for causality with all of the correlational data that's out there. But what I use is existing data sets. I don't go to abortion clinics and interview women. I try to find nationally representative samples where there is both reproductive history in the data set, and mental health outcomes and other variables that can be controlled. And some of the most important factors to control for include the intendedness of the pregnancy. You get the groups are equated a little better if you are comparing women who abort to women who had an unintended pregnancy that was delivered. Although that's not the only consideration, and we can talk more about that, but it's also important to look at the level, the certainty of decisions, the exposure to other traumatic events like interpersonal violence, marital status. There's just a whole slew of variables that ideally we control for so we can more effectively tease out the effect of the abortion.
Okay. So you do use a lot of control factors. I also saw that you did a meta-analysis with over 800,000 women. Is that the correct sample size? And around a number of countries. So it's some large sample sizes that you've used, not a limit.
Well, yes, and with the meta-analysis, it is a quantitative review. So I used existing studies and derived a comprehensive overall effect. And so that study, published in the British Journal of Psychiatry, actually included 22 pre-existing studies from 1995 to 2009, and they're weighted. So what's nice about a meta-analysis is all studies aren't treated equally. The larger ones have more impact in terms of deriving the final odds ratio or the overall effect size.
Okay. All right. Thank you so much. So we'll go into yeah, you can just go ahead and go through the slides with us, and then we'll
Oh,
go into some other questions that we have for you.
okay. Okay. Well, it is important to realize that abortion is unique in medicine because there are two biological entities involved. There's the mother and the child, and there aren't any other similar medical types of procedures. So it is unique because it is the decision that women make is not just a medical decision. It's a philosophical, moral decision. And we do find that when women really believe that the fetus is a human life, and approximately 50% of women who undergo abortions do endorse or agree with the fact that this is a human life. And so then it leads you to wonder, why would so many women be okay with terminating what they believe is a life? And usually it's because they don't see a way forward. They don't have the finances. They don't have the emotional support. And so they almost do it in a self-defense way that it's either my life or this baby's life. So it's really a complex psychological process of arriving at that decision. And often the pro-choice world and the researchers and the community will make the claim that women arrive, it's an easy decision, women arrive ready, knowing what they want, but the data doesn't suggest that. Most women are certainly at least 30 to 40% arrive wanting information, wanting help to make that decision. And this is okay, did you want to advance forward to the psychological impact? Okay. Okay. So if we look at all of the studies that are published worldwide, there are certain outcomes that have been examined more frequently and where we really see robust associations. So depression, anxiety. Anxiety is sometimes measured as generalized anxiety disorder or post-traumatic stress disorder. There are phobias. So a variety of specific diagnoses in the anxiety realm. Also substance abuse. We published a study in 2002 in the American Journal of Obstetrics and Gynecology showing that women who had a prior abortion compared to women who did not were 10 times more likely to use marijuana in a later pregnancy. So sometimes it's down the road that we see these impacts. And then suicidal thoughts and behaviors have been studied. And if we look overall, a minimum of 20 to 30% of women are going to have serious long-term ramifications. It is associated with a higher risk when, even when you look at unintended pregnancy. In my meta-analysis, I did a sub-analysis and found that when compared, just looking at the studies where it was abortion compared to unintended pregnancy delivered, there was a 55% increased risk of mental health problems. So I did notice in the Capri report that you sent me that they do cite to studies, and they talk about how when we're looking specifically at unintended pregnancy, they make a lot of ill-founded claims there about how it will adverse, if it's much worse to have a baby if it was unintended, because then it's going to have adverse consequences on parenting, on the woman, on the child, and there really is not empirical support for that. There is the Turnaway study is all that they have, and maybe if we have time, I can talk about that. It's really making a splash all over the world. It was generated at the University of California, San Francisco, and they have a big center there. It was one data collection effort, and they've generated about 60 journal articles, and they're all based on a very flawed methodology. So it's problematic. Yeah, and there have been studies. The studies that have also compared women who have an abortion to other forms of perinatal loss. There's a researcher from Norway, Broen, B-R-O-E-N, and she's had some pretty dramatic results showing that there is loss and there are psychological effects, obviously, of a miscarriage, but they tend to, over time, dissipate, whereas with women, she had a longitudinal investigation looking at women 2 years out and 5 years out, and by 2 years and definitely by 5 years, the women who had aborted were still suffering, whereas those who had the miscarriages had resolved some of the psychological issues. Yeah, and these are some of the qualities of the studies that are that make, when you look at everything published, you want to examine studies that have large samples, that are nationally representative, that have controls over prior psychological history. In the meta-analysis, out of the 22 studies included, 12 had control for prior psych history, and 2 had proxy variables. And I think it's so interesting. The news is often just so incorrect and biased. And when my study came out, I kept seeing that I didn't control for prior psych history. But if somebody just looked at the journal article, you would see there's a chart that is in the back that explains that 20, depending on how you look at it, 12 to 14 of the 22 had controls. And then these are some of the other variables that we talked about earlier that are important to control for: violence, ethnicity, marital status, religious beliefs, income, education, the planning of the pregnancy, reproductive history, number of children, and available support. And we see lots of studies now that are really tightly controlled, that are good studies that should be informing policy, not this Turnaway study, but it's just so flawed. Prospective data collection is important because you need to establish that the abortion preceded the mental health problems. Use of appropriate control groups. And here's this third one here, the measures of mental health being comprehensive is hugely important, because when you talk about somebody experiencing depression or anxiety, it's not a unidimensional construct. It has many different aspects to it. Any diagnosis of depression is going to consider lots of different symptoms. The same is true with anxiety. And this is one of the problems with the Turnaway study. They had very simplistic measures of their outcome variables. They looked at a lot of different outcomes, obviously, with 60 journal articles, but the depression and anxiety were only measured with 6 items when there are really strong, psychometrically sound instruments available. So that was just inexcusable. And then I was just reading a study, one of their studies where they looked at self-esteem and life satisfaction uh, in conjunction with abortion, and they were measured those two variables with one item each. There isn't another area in psychology that you could get an article published if your outcome measure was one item for something that complex. So it's like when the data suggests that abortion is good for women or doesn't have any ill effects, it's like all the methodological requirements are relaxed, and that these papers fly through the review process, even though they are very poor science. Um, and then here are just some of the studies that Solon's used the Ad Health data, which is nationally representative. It was followed people, adolescents into young adulthood. And he found that he did the population attributable risk statistic, and he found that 8.7% of the prevalence of mental disorders was directly attributable to abortion. When I did my meta-analysis, my PAR was closer to 10%. But we're seeing across studies pretty similar rates and so forth. That gives us, more confidence in the validity of the findings. Then there was one from France, and in this study, they compared surgical abortion to chemical abortion, and they generally found that the chemical abortion was associated with more adverse consequences. And there are different reasons for that, with the medication abortion or chemical abortion, whatever you call it. Women are more directly related to the experience. They take the pills themselves rather than somebody doing something to them. They're often alone in their homes. They often see the fetus. And so medication abortion, which is pitched as more woman-friendly, actually the data that we have now suggests that they're more likely to suffer psychologically. And then this study from France, this was at 6 weeks, 20% at high acute stress and 38% at actual post-traumatic stress disorder. And this is an example of one of those studies where women who had chemical abortion had higher rates of anxiety and grief. And then in Finland, this was an interesting study. Gisler has been publishing on this topic for some time. His first studies, I think, came out in around 2006. But this study in 2015 looks different. He looked at, obviously, a pretty long range of time from 1987 to 2012, interested in suicide trends. And he found that women with a recent abortion still had a twofold suicide risk increase even after they had implemented these care guidelines where women were followed up 2 to 3 weeks after, just to monitor how they were doing mental health wise. And most clinics don't do that. There's usually no follow-up. So even with an intervention like this, women were still at an increased risk of suicide. And then in Germany, two studies recently in Germany came out in 2019, both large. You can see the numbers here, almost 60,000 women in the first one, and in the other one, they generated data from 281 different gynecological practices. And so these are examples of studies that really meet all those criteria we talked about, being large, nationally representative, with good controls and high retention rates. That's another consideration that where the Turnaway study really fell short. And we could, probably might not be a bad idea for me to just talk about that briefly, because the most glaring flaw in the Turnaway study, I believe, was the fact that they retained so few of the eligible women. They had 29 different clinics in the United States, and they didn't provide any information on how they sampled them. They never revealed the locations. and there were 2,000 abortions performed each year at those 29 clinics for 3 years. So the potential pool or population was 174,000 women, and the final result of the Turnaway study is 516 women. That's 0.29%. There's no way that it's representative of women having abortions. It's absolutely ridiculous. But you don't get all that information from their studies. You have to go to their operations manual. And I've really dissected that. And I have an invited paper where I'll be talking about all of this. It's due in September. So I'd really just like to expose, to a broad audience how horrible that study was methodologically. And it's what really is surprising is they had like $80 million that was funneled into the efforts at UCSF, and they couldn't come up with any better than that the extremely broad methodology.
Yeah.
This was one in China in 2018, and this was involved over 5,000 women, and they found that migrant workers who had an abortion were nearly twice as likely to have past year suicidal ideation after controlling for, you can see all of those confounding factors. And then we in Korea, another large-scale study of over 5,000 women. And you might be able to see as we go through these different slides from the different countries throughout the world that, they're coming up with pretty similar results after all those controls. In this particular study, they were 3 times more likely to experience suicide. This one was, that was that one. And then they also were more likely to experience a depressive mood, and also higher with more abortions. So the more abortions women have, the greater the risk for depression, kind of like a dose effect going on there. And then this one is interesting because it incorporated data from several different countries, and they found that women with previous abortion experience, when compared to women who didn't have any prior pregnancies, stress scores were elevated at 15 weeks gestation with 1 and 2 abortions. Depression scores were elevated at 15 and 20 weeks gestation in women with 1 and 2 abortions. So. And this was the meta-analysis that it published in 2011. So we talked a little bit about that, but the largest bottom line was, after pooling the data from 22 studies, 36 different effects, women who have an abortion compared to those who don't have an 81% increased risk of mental health problems. And then there's the data on that. This is from the meta-analysis, this is how the data can be visually displayed. And if abortion were not having any real impact here, all of those horizontal lines would be centered around the middle line, vertical line, and they're shifted into that third quadrant. And so you could even blur your eyes and see that there's something systematic going on there. So looking, and this was what I mentioned, when we look at the population attributable risk, we can say with confidence that nearly 10% of the incidence of all mental health problems was directly attributable to abortion. So if we were to wipe out abortion, we would be saving 10% of the population from suffering from mental health problems. And then here's just, some points of view from people that you might not really expect. Many of the adverse effects of abortion are evident in Jewel Green's testimony. Green is a speaker and writer and former abortion clinic worker. She succumbed to a highly pressured abortion at age 17 and writes, "After spending a month in a psychiatric unit to recover, I worked in an abortion center for 5 years in an attempt to assuage my guilt, normalize my trauma, and rationalize away my pain. I wandered through life trying to fill the void where my baby should have been, academic and career pursuits, moves to different states, marriages. Nothing satisfied me until I started speaking out about the anguish and regret I felt and still feel from my abortion. Rebecca Walker, women's rights activist and daughter of Alice Walker, conveys the impact of such beliefs. She said, the aftermath haunted me for decades. It ate away at my self-confidence, and until I had Tenzin, I was terrified that I'd never be able to have a baby because of what I had done to the child I had destroyed. For feminists to say that abortion carries no consequences is simply wrong. And then there are some other, in addition to mental health, mental illness, mental health diagnoses, there also are other just ill effects, emotions that are impacted. We see in the studies available that women feel guilt in 29 to 75% at that rate. We did some study, a comparative study looking at women in Russia compared to the US. And even in Russia, where abortion at that time, and I believe it's still true, was very common and there wasn't any stigma associated with it at all. And still 49% of the women felt guilt. So that suggests it was an internal rather than externally driven phenomenon. Anger, sometimes the anger is directed at oneself, but oftentimes it's directed at someone who may have pressured the woman into an abortion, parents, a boyfriend, or it could be personnel at an abortion clinic. So the anger is a common impact. And then there's unresolved grief and bereavement. Carol and colleagues, and they don't really have any voiced political views on abortion. And, I see them as very objective researchers. They found that 43% of women reported grief right after the abortion, and a year later, 31% were still reporting these feelings. Then in another study by Carol and Lelos, they found that this one related to men, 35% reported feelings of grief and or emptiness 4 months post-abortion. And these researchers concluded, and again, they're not pro-life or necessarily, they're pro-choice, we don't really know. It's very objectively conducted studies, and they concluded that it was a very sad experience. And then as Beatrice Fedor, an international speaker with a heart to help other women, has said, abortion impacts us long after we leave the clinic. We can't suppress motherhood now and start again when the stars are aligned. Women deserve choices that they can live with. So with knowledge, commitment, effective organization, and compassion, we can assist professionals as they endeavor to empower women to make healthy decisions for themselves and their families. I just love this picture.
Yeah, that was a great presentation.
Thank you.
I've learned so much. Just have a few more questions for you before we leave. I know that.
Okay.
Yeah. So I wanted to go back to where you were speaking about comparing outcomes for among women with unintended pregnancies with those who decide to do abortion, right? So just to put it in the Jamaican context, for example, Jamaica has among about the third highest teen pregnancy rate in the Caribbean. And that many times these pregnancies are out of unfortunate circumstances. But one of the things I wanted to ask, based on the recommendations by the local research group that recommended access by minors without parental consent, based on your previous research comparing outcomes of teens, I don't know if you've done research on outcomes of teens who abort compared to those who carry by term or to term. What do you believe may be the mental health implications of this recommendation for that group of persons in that circumstance?
Well, all the data that's available on adolescents, typically if there is a pregnancy during adolescence, it's going to be an unintended, not too many teens pregnant on purpose. But The available data suggests that they are a high-risk group for psychological problems after abortion, more so than older women. So they are a sensitive population, and if you look at the data published worldwide, and I published a study in 2006 with a national data set with that ad health data that someone's used, and found that they were more seriously at risk. And so I think it's false to say that they would be better off having an abortion to term. They have options when they carry to term. If they're unable to parent, there's adoption. And what's interesting with the intendedness variable is, somebody may say that the pregnancy was not intended, but by the time the baby's born, you're not going to see very many women who look at that baby and say they wish they regret it. They wish they had aborted. But many young women will, after an abortion, will deeply regret the experience. And the intendedness variable is important, but it evolves. It's complicated, and a baby may not initially be intended, but that doesn't mean that the baby won't be wanted when born.
Okay, so just going on to about other types of crisis pregnancies. So we do know that definitely there would be a baseline stress level among women with unintended pregnancy. So otherwise, regarding even more difficult situations, for example, a woman who has a child conceived by rape, have you done any studies or encountered any studies as a researcher that had compared mental health outcomes among these sets of women as well?
Actually, there are a couple studies that have looked at rape. One study was by the researcher by the name of Perry. It's extremely rare for a rape to result in a pregnancy. Under 5% of rapes result in a pregnancy. But the data that's available suggests that women view an abortion after a rape as a double victimization. And so and the data indicates that the vast majority of women, if they carry a child who was conceived in rape to birth, that the vast majority don't have ill feelings toward the child. And some will place for adoption, but not always. So it's very misleading and I think unfair that the medical profession just assumes that women should have an abortion after a rape, when the little data we have suggests just the opposite, that women do okay when they carry to term.
All right. So, how do the mental health outcomes of women who have done abortion compared with those who have had a miscarriage?
Well, I think it's a loss of a baby in both situations. And initially, I think you have comparable rates of depression and anxiety with miscarriage and with abortion. But women who have miscarriages, the data suggests they resolve those feelings of loss, and the mental health declines kind of abate over time. Whereas with abortion, it's often a loss, and there are often emotional and psychological consequences that can continue a lifetime.
Wow, wow. All right. I just have a few more questions.
Okay.
Many of the studies that you conducted had been done in countries where abortion has been legal for decades. So,
Right.
abortionists tend to, those who admit that there are negative mental health consequences of abortion, they tend to only blame it on stigma, right? I think that you mentioned it about guilt in, for example, Korea. It might be based on, or Russia, like more internal factors than external. How do you respond to about the idea that stigma is a major cause of the disorders developing among abortion?
I don't think there's evidence that supports that. I think there have been a few studies where the data suggested that women may have more shame or guilt when they encounter protesters or that type of thing. But there's also data that suggests the opposite, like our cross-cultural study with Russia, where there wasn't any stigma. At one point, 90% of pregnancies in Russia were ending in abortion, so it wasn't really looked down upon, and women had many abortions. So if those women are still feeling guilt and still feeling other kinds of negative emotions, traumatized, that negates that whole theory that it's the stigma, not the abortion.
Okay, that's very interesting. All right. So I'm going to just quickly go into about the poor quality child relationships that was written in the Capri report. That so on page 38, there's a quote that it said that poor quality parent-child relationships are often due to unwanted pregnancy and maternal depression. So, have you conducted any study on the long-term effects for post-abortive women for their future families? For example, do you have any studies that suggest that women's ability to bond or care for future children that they may bear years after committing abortion was hampered?
Yeah, well, the opposite kind of what they are suggesting in that report, that they suggest that if a pregnancy is carried to term and the woman and it was unintended or not wanted, then the maternal bond may be not effective, and the woman may be depressed and the child may suffer. But just the opposite seems to be true in the data. And I have conducted a few studies looking at parenting behaviors at when there's been an abortion compared to a birth. And definitely the data were indicating that there are more problems in parenting when there's a history of abortion in someone's past.
Wow, wow. All right. So I'm gonna quickly ask about commenting on the economic burden of treating and rehabilitating women with psychological disorders. Do these women, post-abortive women, usually get to reintegrate well into the workforce? Because an argument, a very popular argument, is that okay, especially for youth who get pregnant, they are recommending that abortion is important for them to be able to continue their education, for example. But if abortion is really seen to be linked with mental disorders, how do they compare with reintegrating into the workforce from what you've known?
Well, what I've seen in the data that relates specifically to adolescents is that they carry to term, that's often associated with behaviors that are more adult-like, where they become more responsible, they become less likely to use drugs, they care more about pursuing their education, and the adolescents who do the best are the ones who stay with their families, with their parents, who can assist with their child, obviously. But yeah, so I think that, again, just the opposite is true, that they're more likely to be valuable members of the workforce if they carry to term and they feel good about their choice, and they are motivated to protect the child and support the child.
All right, final question. So, given your
Oh,
experience, yes, thank you for your patience.
oh, that's okay. I'm happy to.
All right, given your experience as a well published psychological researcher and based on the dangers you have found, what do you recommend that our government consider for women's health as it relates to the issue of abortion?
Well, I just think that it needs to be an evidence-based examination of what's known. In my read of the report there was cherry picking of studies, and it was not comprehensive. I don't think it's appropriate in Jamaica or any other country to base healthcare decisions and policy from just a very small sample of studies, rather than looking at the comprehensive literature base and looking, and determining what are the most consistent findings and the strongest effects. And we really need to use that data to make decisions. There's one area where there tends to be consensus, regardless of where people are on the political spectrum, and that relates to women at risk. Even the American Psychological Association identified that certain women will be more vulnerable to psychological problems. And in the abortion textbooks, if you read those, they identify the same factors. So things like being ambivalent about the decision, being pressured or coerced into the decision, being younger, feeling attachment to the fetus. So if women are interviewed prior to an abortion and they have some of these risk factors, they really need to be counseled more effectively, and they need to be told that they are at risk. And I've worked with South Dakota for a lot of years, and now that's law that women do need to be counseled with these risks, because there are 120 studies that look at profile of women in terms of demographics, personal history, and so forth. So we do know who the most vulnerable women are. And when you look at so many risk factors, add them up, a very significant percentage of women are at risk. And so I think beginning by basing the laws where there's consensus, but I don't think we're ever going to get consensus on the general mental health implications, because there's just too much motivation from the left in terms of policies, and there's just too much of a push so that they distort the data, as the researchers with the Turnaway study did. So another goal that I have, and I will be on sabbatical next year from the university, and so in addition to writing kind of an expose on the Turnaway study, identifying all the flaws and issues with that, I also plan to publish a paper where I'm going to take all the studies that have been published on this topic for the last 25 to 30 years and rate them according to methodological criteria. I did this preliminarily and covered 20 years up until 18, but now there have been a few studies that have come out in the last couple years, so I want to update it. But what I was finding is by far the strongest studies were the ones that showed that there is an association between abortion history and mental health. We need something like that. Part of the reason I did the meta-analysis was we just need an unbiased assessment of the best evidence, and then that should be used to make decisions like legality or restrictions and so forth. And I just firmly believe the truth is in the data, and when you honestly look at women and their experiences, it's not a healthy choice for a very significant percentage of women, regardless of their age or relationship history or whatever.
Oh, thank you so much,
Oh,
Dr. Coleman.
oh, you're
Learned
welcome.
so much from you, and I look forward to seeing your future studies as well. Um,
Okay. Well,
wishing you all the very best in all of your other endeavors as well.
I appreciate that, and I wish you well there. I wish I could come visit you. I've never been to Jamaica. Maybe when all of this COVID stuff is past.
You're welcome to anytime you want to come over. Right.
Okay.
All right. God
Well,
bless
take care. God bless you. Thank
you
you.
as well. Have a good day.